All right. Good morning, good afternoon, and good evening to all our colleagues joining us from Australasia and around the world. Thank you for joining us for another session of the Australasian Pleural Seminars, also known as TAPS. Remember that you can catch these on YouTube that we've uploaded afterwards if you do miss them. We appreciate everybody logging in live and asking questions and making this a very interactive session. So without further ado, I'll introduce Dr. Ed Fysh, who's here with us today talking about pleural effusions in the ICU and all things related to that. So we're excited to have him. And just as a brief intro, Dr. Fysh is a pleural consultant expert and also works as an ICU consultant. He's joined us at Charlie's here, so we're fortunate to have and work with him on a regular basis now. But he's had quite a bit of experience in ICU and especially with his pleural background, perfect talk for him to give us. So I'll turn it over to him and we'll get started for today's session.
Great, thanks, Dhaval, for the intro. I will just share my screen. There we go. Cool. So it's just not letting me. There we go. Good. All right. Thanks, everyone, for dialing in, and thanks, everyone, for the opportunity to talk about pleural effusion in the intensive care. As Dhaval said, I work in ICU now as well as respiratory and with a strong pleural focus. So years and years ago, I did my PhD with Gary Lee on malignant pleural effusion, and then I returned to advanced training in the ICU setting, and I was really struck by quite how varied and different pleural effusion management was in the ICU setting, and how sometimes haphazard choices and management strategies were without really any evidence base behind them. And only a very short attempt at a literature search quite quickly showed up many editorials and commentaries on systematic reviews of small retrospective observational studies, basically saying we need proper evidence because this is a big deal and it's common. So essentially, I dedicated the last sort of 10 years as at least one of my main research focuses on trying to address the lack of evidence on pleural effusion management in the ICU setting. So I'll just talk a bit about the problem and the condition, where we are with the evidence today, and then I'll take the liberty to just introduce my randomized trial that hopefully will finish this year, and we can hopefully I can come back and present some good evidence after we've done the analysis, etc. So pleural effusion is common in the ICU setting. The American study with Steve Sahn's group in the 1990s showed that 62% of patients in the ICU have detectable pleural fluid on ultrasound. And then our study in WA and a French study tried to address what are clinically important effusions. And we found between 3 and 8% of ICU patients do have a clinically important effusion according to fairly standardized criteria, including whether the clinicians agreed and what size the effusion was. So in Australia, that equates to about 9,000 Australians per annum, so definitely common. But despite this high frequency, there's very little evidence to inform management. And why does this matter? Well, in the ICU setting especially, pleural effusion was associated with impaired oxygenation, prolonged mechanical ventilation and ICU stay, and even increased mortality, especially in a very large American study fairly recently by Bateman et al., which was a coding or data mining study, basically. So detection and management of pleural effusion does seem to have the potential to improve patient outcomes significantly. And one specific thing about the ICU setting is there are significant diagnostic challenges with pleural effusion in the ICU because routine clinical assessments and chest X-ray have quite clearly been shown not to detect even fairly significant pleural effusion due to unique factors in the critical setting, such as difficult patient positioning, the sheer number of lines and devices, post-operative dressings, et cetera, et cetera. So more sensitive imaging strategies such as thoracic ultrasound are necessary for reliable diagnosis. So I've borrowed this image from Andrew Walden's paper in Respiratory about 10 years ago, and I've just adapted it slightly for the purposes of this talk. So definitely want to thank him for his detailed understanding and description of the pleural fluid physiology differences in the ICU setting. So essentially, hopefully you can see this, but this diagram shows the parietal pleura here, the pleural space here, and the visceral pleura here, with systemic capillaries on the left, pulmonary capillaries on the right. So fluid normally crosses from parietal systemic capillaries into the pleural space. And cardiorespiratory disease may increase pulmonary capillary pressure, leading to increased extravascular lung water. And when the visceral pleura becomes inflamed in significant disease, the lung water can then cross directly into the pleural space. The other factor is these here are the stomata or stomas where the fluid is reabsorbed from the pleural space into the lymphatics. And this lymphatic reabsorption is helped by muscle contraction and negative inspiratory pressure. But obviously these things occur in spontaneous unsupported ventilation and are much decreased or non-existent in mandatory ventilation where there is no negative pleural pressure as part of the normal respiratory cycle. The other factor is that supine positioning significantly reduces the pulmonary pressure gradient, causes atelectasis, and may further impair reabsorption on top of whatever's happening to make the ICU patient unwell enough to be in the intensive care. So then what are the causes of pleural effusion in ICU? And really, we don't have a great understanding of this. It's limited, of course, by many patients having a contraindication to drainage. And really, the causes vary fairly significantly depending on the type of ICU setting you're working in and obviously the patient's specifics. But essentially, in several series, fluid overload, compounded by capillary leak of systemic inflammatory response syndrome or sepsis, was blamed in about a quarter to a third of patients. And then parapneumonic effusion keeps coming up as a fairly significant and common cause from between 11 and 43%, depending on the series. And actually, malignancy, even in the ICU setting, is a fairly common and significant cause, obviously in pleural effusion representing metastatic disease, which we traditionally maybe would think was less common in the ICU setting. And then obviously in surgical ICUs, there's the specific effusions that come from cardiac bypass surgery, and then of course upper gastrointestinal surgery as well. As far as we know, Light's criteria remain the best way to differentiate transudative and exudative causes, even in the ICU setting. No other study has managed to find anything better. But the important thing to remember is that many causes can frequently coexist, and this is obviously not an exhausted list of every possible cause. And often there are combinations such as hypoalbuminemia with heart failure, et cetera, et cetera. So as I mentioned before, detection of pleural effusion in the ICU, it can be a little bit more difficult. And so I just wanted to list these key indicators I think, or I use for trying to remember to screen the patient for pleural effusion. So essentially, if there's unexplained or deteriorating respiratory failure, particularly if it's refractory to standard oxygen therapy or ventilator adjustments, etc., then go ahead and just think about pleural effusion. Is there one there? Also, if the patient's showing slightly unexplained difficulty from weaning from ventilation, do think of pleural effusions, particularly because in that weaning phase, while the patient's still ventilated and sometimes sedated, that might be a good opportunity to try and drain the fluid and get them as good as you can before embarking on an extubation, rather than running through a sort of confused, agitated phase, etc., where it might be more difficult or more dangerous. Certainly, if there's unexplained or persistent sepsis or fever that's not responding as expected, then do think of parapneumonic effusion or empyema as definitely a potential cause or contributing factor to failure to respond. So we've talked a bit about imaging in the pleural effusion, but this table from our chapter in a recent textbook was used to really just sort of highlight those differences or details in the ICU setting specifically. But essentially, ultrasound does have significant benefits over X-ray and even CT, with very good sensitivity and specificity, probably as good as CT. And obviously, the great thing everyone knows now about point of care ultrasound, essentially, you can do real-time procedure guidance. It's done by the person looking after the patient, so they can react in real time to findings, etc. It's portable. Most ICU staff have access to it. And certainly you don't need to move the patient around, which compared with CT in the vast majority of units that don't have a CT in their ICU, there's clear evidence that there can be high morbidity and mortality even associated with patient transport, even around different departments of the hospital to radiology, etc. So you could argue that thoracic ultrasound is therefore safer as well. The other thing about ultrasound is you can really quite well differentiate different types of fluid potentially on there. CT can as well, but just in different ways. And there is evidence that you can work out a difference between a transudative and exudative effusion in some circumstances, just at the bedside with ultrasound. So how do we treat pleural effusion, and what are the options and what's the evidence? Well, so essentially it boils down to either making a decision to drain the fluid or to just watch and wait while treating the presumed cause. Obviously, if you're draining, you can treat the presumed cause as well. And actually, interestingly, the French study from some years ago and our study from a few years ago, so opposite sides of the world, found that of patients with what we thought were clinically important pleural effusion, a third of patients were drained as first line, and about 2/3 opted for expectant management initially. So that was quite consistent even in different countries and settings. So what are the pros and cons of drainage? Why don't we drain everyone? Well, initially the pros are that drainage can improve oxygenation, and that's been shown in retrospective data by Gallagher et al. In systematic reviews, and some others as well. And then for the first time in prospective observational data by us in our series of just over 200 patients. So PF ratio can improve by over 20% on average in these patients when you drain the fluid. This is quite different actually to the non-intensive care setting, where the PLEASE trials as many of you will know, have shown that saturations essentially didn't change in malignant predominant effusion. Drainage also can improve diagnosis and or treatment in up to 50% of cases. And once again, that was in both the French study and WA study as well. So change of diagnosis, changing treatment is quite an impressive outcome. And we were slightly surprised by that as well. Which probably goes to show that we're not great at really understanding what the cause of the pleural effusion is without analyzing the fluid. And the third thing that we showed was that early drainage within 24 hours of diagnosis of pleural effusion in the ICU is associated with a higher chance of safe and successful procedures compared to delayed drainage after expectant management. And so what are the cons? Well, drainage complications do definitely occur, pneumothorax, hemothorax, etc. And death does occur from pleural procedures, particularly in the ICU setting, where potentially sometimes the stakes are higher, right? With very hypoxic or unwell patients on high pressure ventilation, etc. But it's very clear from Paul Mayo's study and others that even in the ICU setting specifically, ultrasound does significantly improve safety and is now virtually mandated in the guidelines. The other thing to say is, as mentioned before, drainage has actually been shown to increase mortality, but that was in this large retrospective data mining study, and it hasn't been borne out in any of the sort of prospective observational data to date. So really, with this common problem without great evidence to guide treatment, I and others felt that it was time for a first randomized trial. And so we are undertaking the ESODICE trial, which is hopefully going to finish fairly soon. We've only got 3 people left to recruit. So hopefully we can finish the follow-up and analyze the data sometime this year, fingers crossed. So ESODICE stands for Efficacy and Safety Outcomes of Drainage of Intensive Care Effusions, and the protocol's been published as shown there. So in terms of the trial design, really our aim was to evaluate the safety and efficacy of early pleural effusion drainage compared with expectant management in the intensive care setting. And we hypothesized that early pleural drainage compared with expectant management can improve oxygenation in a randomized setting and is safe. Our population studied is patients diagnosed with a safely drainable pleural effusion while admitted to the ICU, and we're recruiting from 4 sites in Western Australia, 2 teaching hospitals and 2 more peripheral hospitals. Obviously, the patients have to have no absolute indication for immediate drainage. Our co-primary endpoints are the PF ratio at 48 hours after randomization and the number of pleural effusion-related serious adverse events in 90 days. The inclusion criteria and exclusion criteria are there, and I've pretty much discussed them all already. They need to be in ICU, they need to be over 18, the effusion safely drainable with no immediate indication for drainage. And the clinician in charge of treating the patient obviously reserves the right to suggest against entry to the trial, and also retains all control over treatment decisions beyond drainage. But even if they're allocated to drainage, if the person doing the drain decides it's actually not safe, of course they can abandon that. Likewise, if the patient's randomized to expectant management and then the clinician changed their mind and want to drain, of course, as a safety feature, the clinician can go ahead and do that. And the only other exclusion is ECMO, where, of course, PF ratio becomes pretty meaningless. So randomization is open label and in a 1-to-1 patient ratio. Intervention is drainage as opposed to the comparator is expectant management. And there are many other outcomes which I might skip over in the interest of time. So in terms of ongoing goals, if ESODICE does confirm physiological or at least oxygenation efficacy and safety of effusion drainage, then we'll intend to plan larger studies to look at more standard clinical outcomes, including mortality, etc. ESODICE will provide up-to-date randomized trial data on which to base power calculations, etc., for the subsequent trials. So in conclusion, really, pleural effusions are common and can lead to significant morbidity and mortality in ICU patients. Early detection, accurate diagnosis, and appropriate management are crucial to improving patient outcomes. And research is ongoing because more high-quality data is needed to establish guidelines on management of pleural effusion in the ICU. And I'd just like to finish, if possible, with a shameless plug for the chapter in this very good textbook edited by Suvir Singh in the UK and Paolo Pelosi. Thanks very much.
Brilliant. Thanks so much, Ed, for that great talk. It really does open up the idea of what we need to be doing about these pleural effusions. I mean, I always struggled with kind of how to, what to do and how to manage. Usually, my thought process was that if I'm draining something, I'm leaving a drain in. And, obviously that's not always the appropriate thing to do, but I'll have your thoughts on kind of, at least maybe even from the study, how many times you actually leave a drain in versus just doing a thoracentesis and coming out. But yeah, I'll start with that and I'll wait for other questions that come in through the chat.
Yeah, thanks. Yeah, I agree. If you're putting the patient through the relative risk of putting a needle through their chest wall, if it's worth that risk, it's probably worth being able to access the space, drain the space dry, and also, of course, have access in terms of for infection, for thrombolytics and enzyme therapy, et cetera, et cetera. So I'm trying to remember in our observational study, I think the vast majority across those 3 teaching hospitals, the majority were drains. I think of the third of patients that got drained first up, I think about maybe 10% or so with thoracentesis. So and obviously in that study, I had no control over what the clinicians did. I just recorded what they did. So I would say that most people would agree with that that statement. In the randomized trial, we have had some clinicians choose to do a thoracentesis, and we've definitely, tried to keep it as user-friendly as possible so that we can recruit patients and maintain external validity and all of that. And I think really their reasons occasionally were that they thought it was a reasonable size effusion, but fairly free-flowing, and they could get it out in one go and just make sure that they were ruling out other causes. But yeah, I agree. Generally speaking, I just leave a drain in.
And the setting, I mean, in terms of, if the patients are ventilated, which I imagine a majority or a good chunk maybe in the study, how quickly did you see an improvement in mechanical ventilation or just, respiratory parameters?
Yeah, so just from my experience, I typically see the real benefits start to kick in somewhere towards the 24-hour mark. So that's why we picked the endpoint time of 48 hours to give the clinicians time to get around to doing the drain, and then being in that sort of time where you start to see the atelectasis improve, I suppose, with the effusion removal, etc. We definitely do see, and I think there are a few studies reporting on PF ratio after drainage in the ICU setting that have shown a decrease in oxygenation, and almost all of those were looking at, I think they were doing hourly PF ratios for the first 6 hours or something. All of the ones that have looked beyond about the 6 hours, and I guess that makes sense physiologically, because if you're creating a little bit of a shunt as you sort of start to re-oxygenate or reventilate that lung that hasn't sort of fully sorted itself out yet, then perhaps you can then get the hypoxia from that. Yeah.
Absolutely. And questions coming through in terms of volume of pleural fluid removal needed to improve P to F ratio. Any kind of insights into that? I'm sure you're looking at the data, and that will come in the end analysis. But any insight so far?
Yeah, so we definitely found that the larger the volume, the more likely it was to get an oxygenation response. In our prospective data, we did do a dichotomized cutoff in the multivariate analysis that I don't think quite reached significance, but I need to go back and double check. But we looked at greater or less than 500 mils, but the majority of volumes were quite a lot more than that. Yeah. In terms of the clinical significance definition, in our paper, we sort of discussed this round and round and round, trying to pull opinion from many different clinicians. Essentially, we went with a minimum cutoff of 2 centimeters on ultrasound at the maximum depth. And I guess if you believe, so there's a paper by Balak and others for estimating the volume based on the depth on ultrasound. And I thought it was too simplistic. It's 20 times the depth in millimeters, giving you milliliters. So for a 2 centimeter or 20 millimeter effusion, if it's free flowing, head up 30 degrees, and done laterally, then that would equate to 400 mils. And I thought that equation was way too simplistic and couldn't possibly be true. But actually, in our prospective study, it was hard to come up with anything that beat that formula. And maybe its simplicity is good and it should
Absolutely.
stick. Yeah.
Yeah. And so kind of similar to what we talked about a little bit already, but I'll just maybe have you comment on it specifically, is that in the critical care setting, is it beneficial to leave a pigtail drain inside the pleural space for a few days? I mean, I think we said we would place them in a majority of them, but leaving it in before removal, thoughts?
Yeah, I mean, I guess removal depends obviously on the clinical setting. Yeah, my practice is typically to go, I guess, for a small bore or Selding, a modified Selding drain, rather than routinely do a large bore drain. My caveats for that would be if there's ongoing air leak in a mechanically ventilated patient or bleeding, I would probably go to a large bore drain. But yeah, and certainly infection, we can get away with a sort of 12 French-ish drain, as has been discussed in the non-ICU literature, but we now have experience of enzyme therapy in the ICU setting as well, and it is very useful and safe and avoids surgery in the majority of cases. So sorry, I'm going off the question, but in terms of removing the drain, I think if it's causing a lot of pain and not draining a lot, then I would take it out. If it's done its job, I'd take it out as soon as I can, basically.
Yeah, absolutely. And then I think we just have pretty much two more questions and we'll have to end. But in the study where pleural fluid drain improved diagnosis or treatment in 50% of cases, was there a pattern of improvement? An example, removing or discovering infection or that it was a transudate? Was there any kind of signal as to what may have been contributing?
Yeah, I think so the commonest change was actually going from a transudate or a transudative cause, so a pre-drainage assumption that it was an accumulation of, say, heart failure, renal failure, fluid overload, too aggressive resuscitation, for example, before stabilizing the patient, and then quite a lot of those patients that were making it to the studies in the FATUC, the French study particularly, were were then actually ending up being exudative, infected, even malignant. As I said, that was a bit of a initial surprise to me.
Yeah,
Yeah.
absolutely. And then last question for today is it possible that the late change in PDF ratio can be explained by change in management in the intervention group? Meaning you're testing both drainage and change in management based on more accurate diagnosis versus conservative management.
Yeah, so that's, I guess, in a nutshell, what I've been thinking, which is that all of the oxygenation data prior to a study that we published in 2020 was all retrospective and didn't actually have a comparator. So that's what I've essentially been trying to focus on, is get some kind of comparator so that we can know, is it just that the drainage group are getting exactly that, more specific management, and therefore an improvement from that, and then it's not the drain as such that is doing it. And certainly in the sort of control group, so the expectant management group, which was twice as big as the drainage group in our study, it was fairly clear that they didn't have that same improvement in oxygenation. But obviously that was a clinician choice study, and maybe clinicians are smart and can work out which patient's going to get better and pick those for drainage. So that's why we had to go ahead with the randomized trial, essentially. Yeah,
Yeah, absolutely. Awesome. Well, again, thanks again so much, Ed, for spending time with us and giving us your insights. And thank you for everybody for logging in. Remember, these are recorded. You can catch up with these on YouTube if you so desire. And we'll catch you next time in a month's time. And look forward to seeing everybody then. Take care.
great. Thank you.